Hello and a very warm welcome to this special topic lecture. It's an absolute privilege to be speaking today with such a distinguished audience of medical school professors, graduate students, and dedicated clinical researchers. Now, we are embarking on what I think is a truly fascinating exploration of how our specialty, anesthesiology, has fundamentally shaped modern medicine. We're going to be examining some of the most rigorous, paradigm-shifting clinical trials led by anesthesiologists, all published in the New England Journal of Medicine. These aren't just isolated studies. They are the very foundational pillars of perioperative medicine. They dictate how we care for millions of patients globally every single year, both inside the operating theater and in the intensive care unit. Right. Before we get into the data, I want to start by sharing this exact sentiment with all of you, in both English and German, to honor our truly international community of scholars. Hello, researchers. You have worked hard today submitting to SCI journals. Today, I would like to examine research papers by anesthesiologists published in the NEJM, a dream journal for all medical researchers. Hallo, liebe Forscherinnen und Forscher. Sie haben heute fleißig an der Einreichung Ihrer Beiträge bei SCI-Fachzeitschriften gearbeitet. Heute möchte ich die Forschungsarbeiten von Anästhesisten untersuchen, die im NEJM, einer Traumzeitschrift für alle medizinischen Forscher, veröffentlicht wurden. I know firsthand the intense dedication, the late nights, and the immense effort required to produce high-impact science. The trials we are looking at today represent the absolute pinnacle of that rigorous pursuit.
So here's our roadmap for this explainer. First, we'll look at the landmark infection control trials that proved anesthesiologists control the physiological variables that dictate surgical outcomes. Second, we're conquering postoperative nausea and vomiting, diving into a masterclass of trial design. Third, we'll tackle the terrifying complication of intraoperative awareness and the monitoring trials that changed our perspective. And finally, we will look at how our specialty challenges deeply entrenched clinical dogma, moving from surgical fluid management to spinal anesthesia, and even stretching into critical care.
Okay, let's dive into this. We are starting with Section 1, Landmark Infection Control Trials. For a long time, surgical site infections were viewed almost exclusively as a surgical or sterile technique issue. But in the late 90s, that paradigm shifted dramatically. Let's travel back to 1996. Dr. Daniel Sessler and his team proposed a fascinating hypothesis that the mild hypothermia routinely occurring after anesthesia induction actually promotes surgical wound infections. Now, the pathophysiology here is brilliant. Hypothermia triggers thermoregulatory vasoconstriction. This decreases subcutaneous oxygen tension, which in turn severely impairs the oxidative killing capacity of our neutrophils and reduces collagen synthesis. So they randomized 200 colorectal surgery patients. One group received routine thermal care, allowing their core temp to drift down to about 34.7 degrees Celsius. The other group was actively warmed to normothermia, around 36.6 degrees. The results were staggering. The hypothermic group had a surgical wound infection rate of 19% compared to just 6% in the normothermic group. Building directly on this concept of tissue oxygenation, Dr. Robert Greif, Dr. Akça, Dr. Sessler, and their colleagues conducted a double-blind RCT in the year 2000. They hypothesized that simply increasing the inspired oxygen fraction could further reduce wound infections. They randomized 500 colorectal patients to receive either 30% or 80% inspired oxygen. They found that subcutaneous oxygen tension was indeed significantly higher in the 80% group, and the infection rate was quite literally halved, dropping from 11.2% in the 30% group to a mere 5.2% in the 80% group. Interestingly, though, collagen deposition and the timing of suture removal showed no significant difference between the two groups. Now, I really want to pause on this critical number, 2.6 days. In that 1996 hypothermia trial, this was the prolonged duration of hospitalization for the patients in the routine unwarmed group. Think about that for a second. An increase of over 2.5 days in hospital length of stay simply because of an intraoperative core temperature drop of barely 2 degrees Celsius. The health economic implications of this single data point were absolutely massive. This stark reality is exactly why forced air warming, operating room temperature management, and active warming protocols became an absolute universal standard of perioperative care across the globe. And this brilliantly illustrates the elegance of these interventions. When we look at the baseline characteristics of the year 2000 oxygen trial, the predicted risk of infection, things like age, comorbidities, surgical duration, were nearly identical between the two groups. The hospital length of stay remained the same for both groups. Crucially, administering 80% oxygen did not result in any pulmonary function decline or atelectasis complications, which was a major theoretical concern at the time. Now, it's worth noting that this specific trial sparked an enormous amount of controversy and debate, leading to dozens of subsequent follow-up studies.
But as a proof of concept, it was a spectacular demonstration that anesthesiologists, by manipulating basic physiological parameters, can drastically alter surgical outcomes.
Which brings us to our next major era, Section 2, Conquering PONV, Postoperative Nausea and Vomiting.
For decades, PONV has been one of the most distressing complications of surgery for patients. It's incredibly common, and solving it required a trial of truly monumental scale and ingenuity. Enter the 2004 IMPACT trial, led by Dr. Apfel and colleagues. This was an international, highly pragmatic RCT involving 5,199 patients across 28 different centers. But what makes this study a masterpiece of clinical research is its complex 2x2 by 2x2 by 2x2 factorial design. They evaluated 6 different interventions simultaneously to see exactly how they interact. The interventions were Ondansetron, dexamethasone, droperidol, propofol versus a volatile anesthetic, nitrous versus nitrous oxide, and remifentanil versus fentanyl. This created 64 possible combinations. It was an absolute logistical triumph that allowed them to untangle a very messy clinical problem.
So the crucial point is what they found. Ondansetron, dexamethasone, and droperidol each reduced the risk of PONV by approximately 26%. Propofol reduced the risk by about 19%, and using nitro, which means avoiding nitrous oxide, reduced it by 12%. Now, they did find one interesting interaction. Droperidol's effect was significantly more pronounced in female patients. But the most historically profound finding of the IMPACT trial was that, by and large, the effects of these interventions were independent and equal. They didn't cancel each other out. This mathematically proved that combining therapies provides cumulative benefits, and that finding directly established the risk-stratified PONV guidelines we use today. You assess the patient's baseline risk, and you simply stack independent antiemetics accordingly. A true game-changer.
Moving on to Section 3, Monitoring Intraoperative Awareness. We are shifting from physical complications to a deeply psychological one. The phenomenon of explicit recall during surgery is frankly a terrifying prospect. It can lead to severe post-traumatic stress disorder. Historically, in high-risk surgical populations, it occurred in up to 1% of cases. To combat this, researchers embarked on a lineage of studies. First, the Be Aware trial, then Be Unaware, and ultimately the landmark 2011 Bag Recall trial, led by Dr. Avidan. This was a massive prospective RCT spanning 3 international centers, screening and randomizing 6,041 patients deemed high risk for awareness. The trial's objective was to definitively test a major technological assumption. Is the BIS spectral index, or BIS monitor, superior to our traditional end-tidal anesthetic gas concentration monitoring?
The study design sharply contrasted the two approaches. In the BIS protocol group, practitioners targeted an electroencephalogram algorithm value of 40 to 60. Crucially, the standard end-tidal monitors were concealed from the practitioner, and audible alerts were set for the BIS values. Conversely, in the ETAC protocol group, practitioners targeted an age-adjusted minimum alveolar concentration, or MAC, between 0.7 and 1.3, with alarms strictly set to sound if it dropped below 0.7. Now, the prevailing clinical dogma at the time was that a bespoke EEG technology directly monitoring the brain would surely, unequivocally outperform a standard analog gas alarm.
But science has a wonderful way of humbling our assumptions. The results were completely counterintuitive to the prevailing narrative. The incidence of definite intraoperative awareness was actually lower in the standard ETAC group to 0.07% compared to 0.24% in the BIS group. So the superiority of the highly touted BIS protocol was absolutely not established. In fact, the ETAC-based protocol proved to be a highly practical, cost-effective, and robust alternative. Furthermore, both protocols resulted in awareness rates far, far below the historically predicted 1%. And why is that? Because the true protective factor wasn't the proprietary algorithm. It was the rigorous implementation of structured checklists, the use of hard audible alarms, and unyielding human vigilance.
Let's move to our final area and see how this builds into Section 4, Challenging Clinical Dogma. Because if there is one defining trait of modern anesthesiology research, it's that we do not let clinical habits go untested.
A perfect example of this is the 2018 RELIEF trial by Professor Paul Miles and colleagues. For years, Enhanced Recovery After Surgery, or ERA's protocols, heavily advocated for a restrictive intravenous fluid strategy during major abdominal surgery. The thought was that avoiding fluid overload protects the bowels and lungs. But there was growing concern about long-term hypoperfusion. So this international pragmatic RCT randomized 3,000 high-risk patients to a restrictive versus a liberal fluid regimen. The primary outcome was 1-year disability-free survival. The result? 81.9% in the restrictive group, 82.3% in the liberal group, a hazard ratio of 1.05 with a p-value of 0.61. Absolutely no significant difference in survival. However, and this is the vital part, the restrictive group experienced a significantly higher rate of acute kidney injury, 8.6% versus 5.0%. There was also a strong trend toward increased rates of renal replacement therapy and surgical site infections in the restrictive group. This trial sent shockwaves through the community, instantly triggering a massive reevaluation of ERS fluid guideline.
Following that thread of overturning dogma, let's look at the 2021 REGAIN trial by Dr. Mark Newman and colleagues. In orthopedics and anesthesia, there has been this incredibly widespread, almost universally accepted belief that spinal anesthesia is fundamentally safer and superior to general anesthesia for frail, older adults undergoing hip fracture surgery. This single belief drove a massive 50% increase in the use of spinal anesthesia across the U.S. over the years. But here's the catch. That belief was built almost entirely on decades of retrospective observational data that we know is incredibly vulnerable to selection bias.
To finally put this to the test, researchers designed a phenomenal, multi-center, pragmatic RCT across 46 hospitals in the United States and Canada. Now, what's really interesting about this slide is the primary composite outcome, death or the inability to walk independently at 60 days. The relative risk was 1.03. The rates were 18.5% for the spinal group and 18.0% for the general anesthesia group. They were functionally completely identical.
When we drill down into the summary of the 1,600 patients, the equivalence holds across the board. 60-day mortality? No difference. Hospital length of stay? No difference. Even the incidence of postoperative delirium, which was the main theoretical fear of general anesthesia in the elderly, was astonishingly similar. 20.5% for spinal versus 19.7% for general. Now, there was one interesting exploratory finding. Acute kidney injury during admission was actually lower in the spinal group, at 4.5% compared to 7.6% in the general group. But regarding the primary outcomes, this meticulously executed trial completely dismantled decades of observational assumptions. It firmly established that when randomly assigned, these two anesthetic techniques are equivalent, meaning that our clinical decision-making must be based on individual patient needs, not inherited dogma.
As we synthesize this incredible journey through the literature, a very powerful narrative emerges. Anesthesiologists are not merely facilitators of surgery. We are the vanguard researchers, acting as true perioperative physicians. And this doesn't just stop at the operating theater doors. It extends right into the intensive care unit. Consider the 2012 CHEST trial by Myberg and Malomo. Hydroxyethyl starch, or HES, was widely used for ICU fluid resuscitation, but there were whispers of kidney injury. The CHEST trial randomized a staggering 7,000 ICU patients to receive either 6% low molecular weight HES or 0.9% saline. The result, 90-day mortality was identical. However, patients in the HES group had significantly higher rates of renal replacement therapy, persistently elevated serum creatinine, and more adverse events across all subgroups. It fundamentally proved that low molecular weight HES provided no survival benefit whilst actively increasing renal damage, leading directly to international guideline restrictions. Or look at the 2019 SPICE-3 trial by Shahabi and Belomo. Dexamethasone showed great promise in animal models and small trials as an early sedative to improve ICU mortality. So they randomized 4,000 mechanically ventilated ICU patients to dexmedetomidine versus usual care. The 90-day mortality? Exactly 29.1% in both groups, a completely null result. Furthermore, 64% of the dexmedetomidine group required supplemental propofol just to achieve target sedation, and they suffered significantly higher rates of adverse events like bradycardia, hypotension, and sinus arrest. Once again, anesthesiologists used an uncompromising RCT to prove that the strategy of using dexmedetomidine as a sole primary sedative was flawed.
And so I leave you with a final thought to take back to your own institutions, your own labs, and your own clinical practice. As we've seen today, decades of observational data, compelling physiological theories, and deeply entrenched clinical habits can, and absolutely should, be completely overturned when subjected to the uncompromising rigor of the randomized controlled trial. The science of perioperative medicine is incredibly dynamic, and it is far from settled. So my question to you, the leaders and future leaders in this room, is this. What widely accepted perioperative dogma will you challenge next? Thank you very much for your time, your attention, and your ongoing dedication to exceptional medical research.